Thank you, Professor, for an invitation and this opportunity to be here and the opportunity to present the most basic elements when it comes to the subepithelial lesions in EUS. And also here, I would like to thank to my great mentor, Anna Biechowska-Kozłowska, who I work with. And here a couple of words about the general characteristic of subepithelial lesions. So when we think about the wide spectrum of non-neoplastic and neoplastic conditions defined as intramural growth underneath the mucosa, we should think about the subepithelial lesions. So the difference between submucosal and subepithelial lesion is that subepithelial lesion can be located in each part of a GI wall layer, so a GL wall layer. So it's a difference between submucosal because submucosal are generally located in submucosa. So this type of lesions cannot be definitely determined by EGD or even by the different type of imaging examinations. And the most of them are located in stomach. Now the occurrence rised up to 1.7% due to the wideness routine EGD performance. And mostly of subepithelial lesions is asymptomatic. However, minority of them can present some symptoms and even complications like GI bleeding, which are the main indication for the EGD. When it comes to the advantages of EUS examination in cells, we know that EUS is superior to EGD and even to abdominal ultrasound as well as the MRI and CT. Especially when it comes to differential diagnosis, this type of tumor. So with EUS, we can precisely assess the location as well as the origination and features suggestive for some type of tumor. And also what is the most important, we can perform the EUS guided biopsy with obtaining the tissue for histological and also immunohistochemical assessment. And the next advantages is the possibility of evaluation of surrounding tissues, which can assess the stage of the disease and lead us to the indication for the further management. So after the full examination, we can think that this type of lesion, like for example, lipoma, can be left and their further workout is not necessary. However, in some type of lesion, we can think about observation as well as about the concrete treatment. And also with the EUS, we can make the decision considering the type of the resection, if there is any possibility to remove this lesion by endoscopic resection, if there is any possibility, or maybe this lesion should be referred for surgical treatment. And also some guidelines presented that EUS can be the main tool for making the follow-up of this type of lesion. When it comes to the EUS accuracy in predicting the pathologic diagnosis of cells, generally it ranges up to 82%. However, with EUS guided FNA, it ranging up to 98%. So tissue is the issue. And here you can see what is the difference between EUS assessment as well as the different type of imaging examinations, especially when it comes to the comparing solid lesions. So in CT, only 2/3 of the large tumors were visualized by CT comparing to EUS, especially these with size greater than 27 millimeters. And also in a couple of studies, it was presented that EUS was superior in the differentiation cells and extraluminal compression, and it could diagnose 100% of cases. What we should look for when it comes to the extramolar or even intramural lesion, we should think also and keep in our mind that up to 30% of suspected intramural cells are generally extramural in origin. So we should look for the relationship between the lesion and GA wall. We should look also for the disruption of the gastric wall, which will be probably highly related with the subepithelial lesion than the extramural pathology or even normal organ, as well as we should look for the location of the compression, which will be sometimes suggestive for normal organ. And here you can see that some of them can imitate the pathologies, like for example, spleen, which can be visible in EGD, as well as gallbladder, especially in antrum location, and also liver lift lobe, which can also make a compression on a GI tract wall. And here you can see some pathologic condition which can also make a compression. And here you can see the pancreatic cystic tumors, also pancreatic pseudocysts, as well as some vascular abnormalities like aneurysms. And on this picture, you can see some type of subepithelial lesions which were visualized by EGD. And on the left side, you can see that this lesion was referred to EUS examination and also to CT scan examination. And splenic aneurysm was visualized especially by EUS examination. And on the right side of the screen, you can see also some type of subepithelial lesion, which were in fact a normal spleen. So some compression can imitate a subepithelial lesion and should be referred for EUS examination. And what is the most important for the assessment, what we should assess when it comes to the subepithelial lesions? So firstly, we should assess endoscopic appearance, endoscopic features like covered mucosa, like eventual ulceration and depression, and even size. The size is very important, especially when we would like to refer this lesion to EUS evaluation. So if it's hard to assess, generally we can use the standard forceps. And then we will know that the lesion is very tiny lesion like 5 millimeters or 7 millimeters cannot be referred to EUS assessment, but also some of them can have typically a look consistency like in case of lipoma, but also pulsation can be typical for some vascularities. Then we can check the location, which can be also typical for some type of lesions, like for leiomyoma in cardia, but also for ectopic pancreas in antrum. And growth is also very important. It's very important to assess this type of growth, if it's extra or even intraluminal. And these both features, like location and growth, are extremely important when it comes to the qualification for the further resection. So we should assess it before endoscopic as well as surgical resection. And here it's according to the Kim study as well as our study. This is the example of GIST, which can be differently related with the muscularis propria, and which can be differently located in gastric wall. So here you can see that some of that can be dedicated for some special type of resection, like basic endoscopic resection, but also some of them should be referred closely to EFT as well as for surgery. And the most important for subepithelial lesions is the assessment of layers. So we should keep in our mind what is what on EUS screen. And what was pointed out by my great friend, Dr. Nadim Tehami, and what is easy to remember, that muscles are black. So if you are looking for the black lesion, like a hypoechogenic lesion, you can think about the muscle it is arising from, especially when it comes to the cysts, which are rising from the fourth layer, and also from the deep mucosa related to muscularis mucosa layer. And also, it's good to know what is the normal thickness of gastrointestinal wall. When it comes to this, we should remember about 2 up to 4 millimeters, what is usually considered as a normal range, but also the relationship between the mucosa, submucosa, and muscularis propria can be very helpful to assess the thickness of normal gastrointestinal wall. And here you can see the differences between the radial and the linear scope. And if you are not using the radial scope like me, you can just visualize it by the linear scope, and it's easy to perform and easy to assess and to visualize which type of layer is related this lesion. And when you will know what is what in EUS screen, in EUS view, you can think about the layer which is related to some type of tumor, a subepithelial lesion. And here you can see that some of them can be related with a different type of layer, like for example, ectopic pancreas, which can be related, which can arise from the third, fourth, and as well as the second layer. But some of them are typically located in the fourth layer, and this is GIST as well as schwannoma. And here, the next what we should assess during the EUS examination is size, shape, and borders, as well as the content if some type of lesion, subepithelial lesion, includes cystic part. Then you should check where is the debris, if there are septum or a solid component, which is highly suspected for malignancy even. But also we should check the echogenicity and echo texture, what are typically for some lesion. And here you can see that, for example, when it comes to lipoma, you will see that this lesion is hyperechoic, but also some of them, like gastric varices or even cysts, are typically anechoic. So it's extremely important to assess the echogenicity, but also echo texture. If this lesion is homogeneous or even mixed, it's extremely important for the further management. And here, a couple of tips when it comes to the echogenicity. According to Eckhart paper, you will see that some hyperechogenic lesions are generally benign, mostly lipomas, like here you can see this type of lesion, and there is no further necessary for a workup for this type of lesion. But also when we have anechoic lesion, like here, you should think about the vascular lesion as well as the cystic lesion, maybe duplication cyst. And in this case, assessment with Doppler signal can help. But here you can also check the history of the treatment of this patient, because when we have a gastric varices after endoscopic treatment, also in some cases, Doppler signal will be not visible. And some suspected lesion, like mixed lesions, should be also referred for example, EUS biopsy. And here you can see this type of lesion. This is GIST. And this type of lesion is partially solid and it's partially cystic, but also some of them can be an intramural abscess or even complicated cystic lesions. What next we should assess is the type of vascularization, because some of them are very well vascularized, as here you can see the GIST. Also, in some cases, elastography can help, and also in example of GIST, you will see that GIST are more harder than the rest of subepithelial lesions. And very important is to assess surrounding tissue as a stage of the disease and eventual presence of lymphadenopathy if it's visible. Also, the couple of studies presented in last years showed that contrast harmonic EUS can be helpful in the differentiation some type of subepithelial lesions, and especially when it comes to the GIST, some of them can have hyper enhancement pattern, comparing to benign subepithelial tumors, which will have hypo enhancement pattern like leiomyoma. And actually, the sensitivity, specificity, accuracy, it's very high, even up to 100% in this type of tumors. The next, what you should remember and keep in mind, that some of them have some of them then are benign, but also some of them have malignant potential. And here you should think about a GIST, about leiomyosarcoma, about NET, and also metastases. And very important is to know that up to 13% of them have malignant potential. And here I would like to say a couple of words about some types of subepithelial lesions very shortly. As you know, endoscopic features can be very similarly for all of them. And sometimes it's extremely hard to assess these lesions only by EGD. So what we should look for in EUS for GIST is that this lesion typically arising from fourth layer. And most of them is hypoechoic, relatively homogeneous, well demarcated. However, this lesion can be also mixed with calcifications and with some cystic part, like here. And also, as I mentioned before, some of them are hyperenhancement after contrast injection and harder than the rest of cells in elastography. Here you can see both of lesions generally arising from the fourth layer, but also from the second and the third. So here you will see the leiomyoma and schwannoma. These lesions are typically benign, slowly growing. Leiomyoma is typically located in the lower part of esophagus, and schwannoma is located in the bodies of the stomach. However, the EUS features are also very similarly. For example, leiomyoma is hypoechoic, homogeneous, well demarcated and round. And malignant potential is extremely rare in this type of lesion. And also similarly to this, schwannoma is also hypoechoic, homogeneous, round, and there is a lack of cystic change and calcifications, and also the malignant potential is extremely rare. And here you can see the connection with the layer that you will see that is arising from the fourth layer for leiomyoma, which is well demarcated, which is oval, hypoechoic and homogeneous. And similarly to this, you will see here the connection with the fourth layer for the schwannoma. And this type of lesions, subepithelial lesions like GIS, leiomyoma, and schwannoma, are sometimes difficult to differentiate even with the sonographic evaluation and the sonographic features. So always you should perform the biopsy with immunohistochemical assessment. And here you will see that some of them have typical markers in immunohistochemy, which will help to estimate the final diagnosis for them. And here you will see the aberrant pancreas, which is sometimes looks very typical in EGD, which is covered with normal mucosa, normally is located in the antrum. This is type of benign lesion and have some umbilication on the top of this. However, when it comes to the EUS assessment, aberrant pancreas, it's arising from the third and fourth layer, but also can arise from the second layer. It's heterogenic, hypoechoic, sometimes even mixed, but rounded and with indistinct margins like you can see here. And when it comes to the aberrant pancreas and malignant potential, you should know that it's extremely rare. So probably further workup is not necessary in this type of lesions. Here you will see lipoma, and lipoma are typically located in stomach, are benign lesions, and endoscopically have some typical signs like pillow signs. They are yellow hue, very smooth lesions, solitary. So sometimes diagnosis based on EGD is typically, and this type of lesion doesn't need further workup. But in EUS examination, you will see that this lesion is arising from the third layer, is homogenic, hyperechoic, typically hyperechoic with the clean, regular margins. And in this type of lesion, the malignant potential is none. So you can see here on this type of video, thanks to Professor Okasha, you will see this type of hyperechoic, homogenic lesions like lipoma. Okay. And the next one will be a differentiation between duplication cysts as well as between gastric varices, and this is my favorite one. So you will see that sometimes it's not so easy to differentiate the gastric varices and duplication cysts, especially when we have multiple duplication cysts and not so advanced gastric varices. So in endoscopy examination, it can look similarly. However, in the most of cases, gastric varices are more advanced and have typically signs. And in EUS assessment, they arise from the second and the third layer, are anechoic. However, you can see the changes between. So in case of gastric varices, it will be tubular serpineous type of lesion. And in the case of duplication cysts, this type of lesion will be round, oval, with posterior acoustic enhancement, what is typical for duplication cysts, and also will contain from 3 up to 5 layer walls. And when we should consider FNA in this type of lesion, here you can see that Probably in standard EUS examination, they can look typically similarly even. However, after using Doppler EUS, you will see the difference with blood flow for gastric varices and without for duplication cysts. So generally, FNA is not indicated in gastric varices; it's contraindicated, so you will know it. But in case also in typically looking duplication cysts, with a clearly anechoic sign and in EUS assessment, FNA should be avoided due to high risk of infection. Next will be the differentiation between granular cell tumor and carcinoid. These lesions are not so off. Carcinoids are typically located in rectum, so we cannot observe so often in stomach as in rectum. But granular cell tumor are typically located in esophagus. Sometimes it's easy to predict the type of lesion based on endoscopic features. However, in EUS examination, they are arising from the second and even third layer in case of granular cell tumor. And in EUS examination, you will see that this lesion in case of granular cell tumor are hypoechoic, homogeneous with smooth margins like here. And for carcinoid, this lesion will be mild hypoechoic, sometimes even isoechoic, homogeneous with well bordered. And then we will go for inflammatory fibroid polyp, which is rare benign lesion located typically in stomach, with sometimes it's easy to assess it with EGD. They arising from the second and fourth layer and third layer and are hypoechoic and homogeneous with indistinct markings. However, in case of glomus tumor, you will see that this lesion generally don't have specific findings in EUS examination. So sometimes only EUS features are not sufficient to establish the diagnosis for this type of lesions, and they can include a halo in EUS examination. There is a couple of lesions which can mimic subepithelial lesions in gastric, and here you should remember, here you should think about gastric carcinomas, which you should look for the third layer, and they are usually where demarcated masses. Here you will also check the gastric lymphomas, endoscopically see as erosions with ulceration sometimes. However, you should look it for EUS examination, like a thickening of the gastric wall. Especially, you should look for gastric lymphomas between the second and the fourth layer with the layer disruption, and you will see it here. And in case also in gastric lymphomas, you should look for the lymphadenopathy, and the biopsy should be performed also with surrounding lymph nodes. And sometimes metastasis, which with the prevalence for them is up to 5.4%. They can be visible in stomach, in body stomach, in fundus, sometimes with a depression like here. And there is no specific findings in EUS examination for this type of lesions. And sometimes also the standard endoscopic biopsy is enough to set the diagnosis. And here you can see the stepwise algorithm for the workup of incidental GI cells from EGD to tissue acquisition through EUS. So you will know when you will assess some type of subepithelial lesion, for example, the size, typical endoscopic appearance, you should know that the lesions below 1 centimeter are rarely symptomatic and even malignant. So endoscopic follow-up in 1 year is recommended. Also, ESG recommend the size of the lesion to 2 centimeters. And when you will see and during the follow-up that the lesion is growing and have some suspicion features, you should refer this lesion for further characterization in the EUS examination. So the appearance, endoscopic appearance, as well as the size will required for the further management. And if you will have greater lesion, greater than 2 centimeters or 1 centimeters, you will refer this lesion for EUS examination. You should check if this lesion is located extramorally or even intramorally. So in case of subepithelial lesions, we will look for intramural location. And a couple of tips when it comes to the examination of subepithelial lesions with linear scope. So ESG suggests 2 possibilities. One is the installation of water into the lumen, and in some difficult location like fundus, you can change the patient position, and also higher frequency mini probes, if they are available, can be used for the EUS examination of cells. However, from our point of view, what can be helpful is stomachache desufflation, also getting close to the lesion by suction, and very gentle movements of the scope upward and downward to assess the borders. And here you will see the general rules when it comes to the EUS guided biopsy of subepithelial lesion. The first is the tumor size, as I mentioned before, and the second one is endoscopic and EUS examination of the lesion with assessment of features, which I pointed before. And when you will have EGD assessment as well as EUS assessment, and you will think about the biopsy, you should think about the size and about the layer. So some of them can be referred to jumbo forceps biopsy, also to endoscopic submucosal resection, but also we can perform FNA or even FNB, and also refer the lesions for surgery if it's indication. However, in current data, we can observe that you can perform the standard forceps biopsy, also tunnel, and even bite-on-bite biopsy as ESG recommend. However, this type of biopsies have a different diagnostic yield and sometimes are time-consuming, especially when it comes to the tunnel biopsy, like you can see here, the tunnel biopsy, and also can be related with severe bleeding. And in case of standard forceps biopsy, even bite-on-bite biopsy, they can only have access to the subepithelial lesions located in mucosa or even submucosa only. So generally, they are dedicated for very, very superficial subepithelial lesions. And here are a couple of tips when it comes to the EUS guided biopsy. So you know now that the lesions in size greater than 1 centimeter, even 2 centimeter, will be referred to biopsy. However, in some cases of even large tumor, with indication for surgery, biopsy may be crucial for the neoadjuvant therapy. So it depends on centers. So you should contact with the center, especially oncological one, and maybe set together the management for this type of tumors. The biopsy should be always performed for hypoallergenic, mixed, and isoallergenic lesions, and especially for them when we suspect the malignancy. And when we should administer the antibiotics, especially then when we have a cystic lesion or the solid lesion with cystic components. And also you should remember about the Doppler examination before the EUS guided biopsy to check the surrounding vascularization, but also Doppler can exclude the lesions which should be referred for biopsy, like cysts as well as varices, but also sometimes it's difficult to differentiate even cysts from leiomyoma when it's very anechoic. Like here you can see the leiomyoma which can imitate cyst. So then sometimes in some cases some extra examination in EUS should be performed. And here, what is the most important from EUS guided biopsy with tissue acquisition? So of course, histological assessment, but also the most important now for us and for the most of lesion is immunohistochemical assessment. It's crucial for the diagnosis and for the differentiation, especially that immunohistochemical assessment can help us to assess some specific markers for them. And also very important is in some type of tumors to assess the mitotic index as well as Ki67. And here Here can be very helpful these two types of needles like Acquire and Procor, 22 or 25 gauge. And when it comes to the diagnostic yield of EUS FNA, it's up to 93%. And what can be helpful in case of small lesions, mobile lesions located in the stomach, the 25 gauge needle. And you should keep in your mind that complications after FNA of subepithelial masses are very rare. And sometimes you can find in some current publications you can see the question if the 19-gauge needle or even true-cut biopsy should be used for subepithelial lesions. And in prospective studies, the diagnostic yield for this type of needles was about 63% for accessible only lesions, with technical failures up to 14%. And also the data reported some septic complications during using this type of needles. And also presented data showed that mitotic counts cannot be reliably assessed with this type of needles. And at least two prospective comparative studies presented that sometimes 22 gauge FNA needle may have a higher diagnostic yield than 19 gauge needle. And the last one from the EUS guided biopsy technique, what was also presented in current studies, that 4 passes is enough. So after 4 passes, you will achieve the plateau for the diagnostic yield. And also fanning technique with suction, it's preferable method for the tissue obtaining from subepithelial lesions. And here you should remember about the checklist, 1 and 2nd and the 3rd step for the EUS examinations of subepithelial lesions. So firstly, remember about the assessment of endoscopic and endosonographic assessment of features. The next step about the location, some homogeneity and additional features. And then you will go for EUS, FNA, or even FNB, or maybe you will refer the patient for the surgical treatment. And this is enough what I would like to add to subepithelial lesions. So thank you so much.